Pancreatitis is one beautiful example of an inflammatory process, so that discussion regarding the inflammatory response will certainly apply here again. This inflammation, although has nothing to do with an infection, bacterial or viral, but an alteration in the secretion of exocrine enzymes necessary to digest proteins, fats, and carbohydrates, and begin the absorption of these substances in the small bowel. There are mild forms, where admission to the hospital is a few days, to severe, where mortality is very high. And for the most part, management is supportive unless the inflammation is a direct cause of issues with the gallbladder, but more on that later. As with anything, there are patterns to disease processes, such as age, but you don't want to pigeonhole patients into these categories necessarily. And as with any disease process in isolation, it is much easier to treat than if you have comorbidities that accompany it, making it much more difficult for the patient to survive just another organ failure. Typically, and in this presentation, pancreatitis is an acute process, but yes, there are cases where a chronic condition occurs after repeated bouts. The problem compounds when the pancreas begins to bleed, and I will address that in a bit. A review of the anatomy and physiology of the pancreas is probably in order to help you better understand this acute process. The pancreas is an elongated, lobular gland that sits in the retroperitoneal space, and that is important to remember. The vena cava, the aorta, the kidneys, they all lie in the retroperitoneal space. It is behind the stomach. It has both exocrine and endocrine functions. You are all too familiar with the endocrine function, as you have learned about diabetes, but now it is time to focus on the exocrine function. Endocrine glands secrete hormones directly into the bloodstream, whereas exocrine glands secrete substances through a duct either outside the body or into another area in the body. The pancreas secretes the enzymes amylase that breaks down carbohydrates, lipase that breaks down fats, and proteases that break down proteins into the duodenum. These enzymes are not activated to begin the digestive process until they are in the duodenum. The problem lies when the pancreatic duct becomes obstructed. So for this lecture, focus on the green ducts. When those enzymes are activated within the pancreas itself, autodigestion of the pancreas occurs. The two most common reasons for the development of acute pancreatitis are gallstones and excessive alcohol intake. It is thought that alcohol causes duodenal edema, thus blocking the ampulla of Vater, which is the exit point to the duodenum. I have a picture of that coming up. There are other less common etiologies, some of which can be found here, but the end product is still the same. The enzymes cannot get out of the pancreas in response typically to food intake or alcohol, and instead of getting activated in the duodenum, they get activated in the pancreas, and the pancreas begins to digest itself. Without getting immediate treatment, the autodigestion process continues, and the pancreas begins to bleed. This is termed hemorrhagic pancreatitis, which is the very severe form. Injury to the pancreatic tissue results in activation of that inflammatory response. The capillary beds within the pancreas become very leaky, and fluid will move out of the intravascular space into the peritoneal and retroperitoneal spaces. Ultimately, this could result in the development of systemic inflammatory response syndrome, better known as SIRS, S-I-R-S. You will also learn about this in due time. Early management requires careful considerations as to the cause. Here is that picture that I promised you. Notice the green ducts again. The gallstones are occluding the pancreatic duct as well as the common bile duct. at the entrance to the duodenum at the ampulla of Vater. The pancreatic enzymes are blocked from exiting the pancreas. But what can also happen is that the liver can become affected due to obstruction of the common bile duct. Liver enzymes may begin to rise also, and the patient could present jaundiced. This etiology is an easy fix. Remove the stones within the first 24 hours of admission and remove the gallbladder when the patient stabilizes. Repeated bouts of acute pancreatitis could result in a chronic state, and fibrotic changes begin to occur, very similar to the fibrosis in the liver with cirrhosis. The classic signs and symptoms of pancreatitis has much to do with the pain. The patient will present with complaints of sudden, severe, unrelenting epigastric pain that radiates to the back or flank area, usually within 30 to 60 minutes of intake of a fatty meal or excess alcohol. Because the pancreas is inflamed, the pain is somewhat relieved when the patient sits up and it drops away from the diaphragm. Because peritonitis could result, the patient may feel better laying in a ball on their sides with their legs curled up. The patient typically has nausea and vomiting. With the development of peritonitis, the abdomen can become very distended and rigid, and the bowel goes quiet, better known as a paralytic ileus. The inflammatory response wreaks havoc on the vascular system, as the patient becomes intravascularly dry and will present with signs and symptoms of hypovolemic shock. The cause needs to be quickly identified and supportive care initiated, as these patients can become very unstable very quickly. Albeit rare, these two signs are also very classic to pancreatitis. Continued digestion of the pancreas results in hemorrhagic pancreatitis, and the patient begins to bleed into the retroperitoneal space. Cullen's sign is an obvious ecchymotic bruised area around the umbilicus, and Gray-Turner's sign is an ecchymotic area in the flank areas. You may also see ecchymotic areas around the groin area. Hypovolemic shock is the end result if interventions are not initiated quickly due to the fluid shifts from the inflammatory response and external fluid loss from vomiting. One area where fluid will migrate to is into the pleural space on the left side, causing a pleural effusion. I have attached a good example of what it looks like on a chest X-ray. Hypoperfusion to other organs can result in ARDS, acute kidney injury, and acute tubular necrosis. The pancreas begins to shut down and blood sugar levels rise. When I think about chronic pancreatitis, think about a pancreas that is broken. There will be absorption issues, therefore weight loss, and the patient will develop type 2 diabetes. The two labs that will be monitored during this acute phase and very specific to acute pancreatitis is amylase and lipase, as these levels will increase in the blood through the autodigestion process. If the liver is involved also, you will see elevations in the bilirubin level as well as liver enzymes. Because of the inflammatory response, the white blood cell count will rise. The calcium level will drop for a few reasons, but mainly due to fat necrosis. And you have already learned that patients who drink typically have poor diets, so magnesium levels are also typically low. The inflammatory response and SIRS will lower a platelet count as your body is attempting to fix an injury. Depending how much bleeding is taking place, the H&H can go either way. If not bleeding yet, but there is massive fluid shifts out of the intravascular space, then they will be hemoconcentrated and your H&H levels will be elevated. If the patient is actively bleeding, the levels will go down. Be vigilant with trending the creatinine and BUN level, as hypoperfusion can very quickly affect that finicky kidney. I attached a picture of hemorrhagic pancreatitis. There are some very big words on this slide. Initially on admission, the patient may have an abdominal ultrasound to quickly try to rule out other life threats, but will most likely then go for a CAT scan or MRI. An ERCP is a procedure where a scope is used to enter those ducts in an attempt to quickly remove gallstones, if in fact they are the reason for pancreatitis. And has been stated earlier on other presentations, anytime the patient has a scope, you have to worry about your cough and gag reflex. Your assessment then needs to be all-inclusive, as pancreatitis can affect other organs that creates a very sick patient. The patient will be made NPO until the pain subsides, as the goal is not to further stimulate the pancreas. Bed rest with bathroom privileges is ordered so as not to increase peristalsis, which could cause the pancreas to want to release its enzymes. To try to keep the patient hemodynamically stable, crystalloids will need to be infused. Antiemetics are administered to stop the vomiting and prevent further episodes of hypovolemia. Typically, this is not an infectious process, so antibiotics are not ordered unless there is evidence of peritonitis or SIRS. With the possible compromise to the lungs secondary to a pleural effusion, oxygen may need to be administered to maintain the pulse oximeter at greater than 92%. Another main focus is pain management with opioid narcotics. It is most preferred that the patient be placed on a PCA pump to best manage their own pain. The period of time that a patient remains NPO depends on the length of time the patient has pain, as you don't want to feed them if pain continues. If only a couple of days, then no worries. But if the episode of pancreatitis is more severe and the albumin level begins to drop, then it is time to think about enteral nutrition, preferably below the level of the duodenum. Once the pain is relieved, the enzyme levels have returned to near normal, and bowel sounds are present, the patient can begin to eat, very lightly at first, followed by a low-fat, no-alcohol diet. Patients in a chronic state can benefit from pancreatic enzyme supplementation to assist with the digestive process independent of the pancreas. Due to the stress on the GI system, proton pump inhibitors or H2 blockers may also be ordered. Smoking can put stress on and stimulate the pancreas, so cessation is suggested. Repeated bouts of pancreatitis can result in pancreatic cancer. You can see here then what the ultimate outcomes are for this patient. Along with a low-fat diet, patients are discouraged from eating spicy foods, drinking coffee, tea, or sodas, and intaking any gas-forming foods to prevent stimulation of the pancreas. It is also best that the patient avoid alcohol altogether. This ends the presentation on pancreatitis. If you have any questions, please don't hesitate to ask your instructor. Thanks for listening.